This is Breakout Session B, Health and Safety for All, a Vision for Drug Policy in Minnesota. I'm Will Cooley. I'm the Policy Director at MNJRC. Don't forget, if you're here for CEUs, CLEs, whatever it may be, to initial by your name in the back so we can make sure that you get those. But I'm going to turn it over to the presenters to introduce themselves, and then we will have time for Q&A at the end. Thank you.
Great, thank you. Let's see. I just want to make sure, sorry, my mouse is being a little bit funny. All right, well, anyway, hi everyone, good afternoon. My name is Arielle McHenry. I'm a drug policy and harm reduction policy consultant. I'm also a researcher and the coalition administrator for Impact MN, a new statewide cross-sector coalition pursuing health-based approaches to drug use, which you'll hear much more about in the presentation. I'm here today with my good friends and colleagues, Lori Wilson, Chaz Anderson, and Ann Siegler. And we're here today to talk to you about the state of drug policy reform in Minnesota. So before I fully kick us off, can I ask each of you to give just a brief bio of who you are and what you're doing here?
Hello, good afternoon. Yep, it is this afternoon. My name is Lori Wilson. I am the newly appointed CEO at Turning Point. Turning Point is a culturally specific organization located in North Minneapolis. We primarily serve African American men, but that is not it. We also have an inpatient program, an outpatient program, and residential housing.
Great. Good afternoon. My name is Chaz Anderson. I'm here today on behalf of Drug Policy Alliance. And my background, I've been working about 9 years at the state capitol through a business that I own. I've been working on criminal justice reform issues, everything from drug sentencing to civil asset forfeiture reform, to driver's license suspension, expungement, so kind of the wide range of issues on criminal justice reform I've been working on proudly for about 9 years at the state capitol. So thanks for coming up to our session.
Thanks, you three.
Don't
Forget me.
Oh, I'm sorry, Ann. Moving on.
I'm wearing my invisible cloak. My name is Ann Siegler. I'm here today as the researcher, and I'm an epidemiologist by training, and I study the intersection of criminal justice, criminal legal system, and drugs. Worked in harm reduction for many, many years, and I've worked in the government sector for many years, too, at health departments. And yeah, excited to be here.
Okay, now we're ready. So thank you. Okay, so Ann was just talking about research, and the reality is that we have decades and decades and decades of research that's documenting the harms associated with criminalizing drugs. Finally, as a result of that, over the past, I don't know, call it a decade plus, policymakers nationally and in Minnesota have finally decided to take a different approach to drug policy, and that's one that's based in public health and rights rather than criminalization. In Minnesota, this has included a lot of things, especially in the last few sessions. Obviously, we legalized cannabis. We legalized drug paraphernalia. This is a first in the nation policy. We created funding for overdose prevention centers. We created the task force on psychedelic medicines. There's now funding for culturally specific recovery communities. We've removed some barriers to public assistance for people who commit drug offenses. You can hear more about that policy in the next session at the SNAP session. So really when I say we, I mean a large group of people. I mean policymakers. I also mean community groups. I mean citizen lobbyists and professional lobbyists. I mean doctors and lawyers and people with lived experience all have come together to create this big push. And we don't want to stop there. So what we want to talk about today is this three-legged stool of drug policy reform. It's not the sexiest metaphor, but I think it's the best one that encapsulates what we're doing here. So there's three kind of distinct but linked pieces of this project that colleagues here and I are working on. There's a research report, there's a state task force, and there's community engagement and coalition building. So I'm going to give a high-level overview of these three pieces. and talk about what each of them can do and what none of them can really do alone. So the first thing is a research report commissioned by the legislature, with leadership from Representative Pinto, who's here, thank you, Representative, and Senator Claire Umer-Verbaeten, about what good drug policy looks like. And one of our earlier panel presentations was talking about, like, what is the metric that we use to measure these things and how the metric is so important. Traditionally, drug policy has been measured by looking at how many kilos of heroin were seized at the border, how many drug busts, and you see these like, you see this on the nightly news, right? You see all the guns laid out on the table with a pile of pills. And what Ann and I determined when we were writing this report was that that metric wasn't actually useful. What we were more interested when we were evaluating drug policy is looking at health and safety impacts for communities. And when you're looking at health and safety impacts, then you end up having a very different conversation about what good drug policy actually means. So that's the first thing, the research report. The second thing is the state task force. The state task force was established to make sure that this report doesn't just live on a shelf, which so often happens, that it's actually discussed and lived and made actionable. So Chaz and I and some others worked together with Representative Pinto to create a really robust task force that includes people from across Minnesota with professions like doctors and law enforcement and people who know about criminal justice reform and researchers, and they're all coming together and they're looking at the recommendations that are in the report and saying, these are the ones that are really important. We absolutely think that these should move forward to the legislature. And that's valuable from a political perspective to have real-life Minnesotans agreeing on things, including sometimes sheriffs and doctors being on the same page, which doesn't always happen. And the third piece of this is, oops, what did I do from current slide? Hang on a second. IT support, please. Oh, wait, did I do it? Okay, oh, I'm back. Okay. Okay, and the third piece of the three-legged stool is community engagement and coalition building. And this is happening via this new body that we've created, Impact MN. It's very similar to the task force in some ways, but it's sort of the outside game to the task force's inside game. This is communities, people with lived experience, holding legislators' feet to the fire, and building community support for some of the research that was unearthed in their report. So each of these things are mutually reinforcing, we hope. Each piece adds a unique element to the project, and we hope that this is ultimately more than the sum of its parts, that these things kind of create a snowball effect that moves us all forward. So the last thing I want to talk about before I turn to the panel and ask them some questions is this moment that I've been thinking about since the election. And it's this gap between what the people feel and what the experts say. And I think it's come out in a lot of different places. Certainly, I think, like, with the state of the economy, you know, economists were saying, like, the economy is great. Why is everybody talking about this vibe session? And people were saying, actually, like, I can't afford eggs, and that's real to me. I think we hear about it as well in this question of public disorder that comes up about public drug use and homeless encampments, where it's like, the researchers saying that crime is down, you know, it's declining everywhere. And people are saying that they have a real problem with public disorder in their communities, they feel it really deeply. And so there's something that the research can't always catch, and that is nevertheless true. So I've been thinking about how to grapple with this in drug policy so that our movement is successful. So I'm gonna pause there, and I'm going to ask the first question of my panel. And this question is for you, Ann. There's a lot of reports out there, as we were talking about. I think Representative Pinto sponsors a couple each session. What's unique about this one?
Good question. So I think the first piece that's really unique about this is what you already spoke about, Ari, which is that in the majority of reports that look at outcomes of drug policy, we're looking at public safety outcomes. And we took a very expansive approach to looking at outcomes that included health, safety, and people's well-being, so that we can really look at a drug policy in its most kind of holistic way to see how is it really impacting the way that people live their lives on a day-to-day basis? Not just how many arrests are being made, how many people are being locked up, that sort of thing. And we looked at this at both the individual and the community level, which I think is another unique part of this report, with a particular lens on social and ethnic and racial inequity, which I'm sure everybody in this room knows Minnesota is winning for the most terrible racial inequities when it comes to drug-related outcomes, among other things. So particular lens on that. I think another thing that's unique about this report is that it came from the state legislature. It's not coming from a think tank. It's not coming from advocates. This was started by legislators here in the room saying, what does the evidence say, and how can we use evidence to promote the best policies moving forward, which is something that is, as far as we know, no other states have paid for a look at the evidence before launching into policy change. So that's really unique too. I think the last thing I'll just say that I think is unique about this report is we used what's called a whole of government approach, which keeps in mind that the ways in which some things may be enacted in some areas of government can directly conflict, counteract, and work against other areas of government. And so in order to really improve the lives of people who use drugs, the communities around them, we need to be looking at all of the ways in which the different parts of government intersect to work together and not at cross purposes. The perfect example that I always give is like when you have a homeless encampment and the government has contracted out to homeless service organizations to go around and hand out hygiene supplies, including safer drug using supplies such as syringes, naloxone, that sort of thing. And then the next day, the cops come and clear the encampment and confiscate all of those things. So we as taxpayers have paid for those supplies, and then we have paid for them to be confiscated. So what would it look like if all of government was working together towards a common goal that served everyone's purposes? There's lots more to say, but maybe I'll just stop there.
Thanks. And one follow-up question I have for you, Anne, before you put the microphone away, is that our mandate was to create this holistic report. And I think sort of what you're gesturing at with this, the whole of government approach, is that we looked very holistically. I think oftentimes, like you said, people think that drug policy is just public safety or it's just healthcare and treatment. But can you sort of say in a sentence or two the whole breadth of what we looked at in that report?
Yeah, sure. So we took the approach of dividing our analysis into 4 main areas, which I think maybe will help you get a little bit better, like clearer sense of what we mean by a holistic approach. So the one that we typically think of when we think of the outcomes associated with drug policy falls under the area that we call drug policing. And then the other 3 areas are healthcare, which includes things like medications for opioid use disorder, access to mental health care, that sort of thing. Harm reduction, which includes syringe access, overdose prevention programs, that sort of thing, taking into account the full spectrum of use and that people's use kind of recedes and goes up and down over a life course. And then last but not least, the social determinants of health, which is the way in which we know that things like housing, jobs, access to healthy food, transportation can impact the ways in which people can receive or not receive all of those other things that we just talked about. So that's kind of in a nutshell, and I'm happy to go into it in more detail in the questions if people are interested.
Perfect. Thank you so much. So I'm going to pivot to Lori now. Lori, I'm going to ask you more about this question about research in your community, but before we get there, what has been the impact of the war on drugs on the foundational African American community in North Minneapolis? And if you could define foundational African American community for the group as well, I think that would be helpful.
Sure. When you talk about foundational African American community, you're actually talking about those who were brought over here, and so those are, my grandparents, my great-grandparents, those, and that's kind of who we're talking about. We're not talking about the African community that has come, as of recent. So just in terms of the drugs, I'm more with North Minneapolis. I was looking at the stats this morning because I was trying to prepare for this, and African American has been the notion of the folks who are dying. We are like 10 times more than any other community. And so when you look at that, I looked at the Hennepin County numbers, and I'm gonna look at my notes, but we had 373 opioid-related deaths in 2023 that just came out with Hennepin County. And you think about that, and of that, 148 of that was African American, and 134 were white or non-Hispanic individuals. And so you look at that disproportionate level of deaths, and so North Minneapolis, like I said, I'm at Turning Point. I've seen individuals that come in that are 60 plus, and I've seen the 18 and just right at 18, and it's crazy when you think about it, especially the older community, because in my mind, it's kind of like, man, how did opioid use affect you? How did that happen, right? And so, because we've gone through other types of drugs back, in the day, right? And so, you kind of think, well, how did that transpire? And then you think about mental health, when we talk about, when I can't think of his name, Dr. P or whatever his name was, I'm sorry, that was the guest speaker. You talk about trauma and the trauma that the African American community has gone through and continues to go through, right? And so it just goes down deep, and it goes down to, what is the root cause of it, and why are we resorting to opioid use and drugs? And so it's been really an eye-opening experience in terms of seeing the numbers that we had. Honestly, I should be full every day. I should be turning away people. But we're not, because people are scared of what happens. The trust level has changed, and so the community itself has changed as a whole. So it's been really devastating when you think about it, and the folks that we serve. We are primarily male organization, but we also have outpatient, which we're handling women as well, and that the impact on that and the children that you think about. It's just this it's disheartening, and it's like, how do we, as a community, how do we try to fix this? How do we, where do we start, really, has been the big question.
Thanks. So, yeah, maybe you can tell me a little bit more about how has the community responded? And I'm thinking about, what is the community? I'm thinking about the question I have is, what is the community built? Like, how is the community dealing with this? How are they responding?
Yeah. So it's funny, we were talking earlier about North Minneapolis and Minneapolis in general. Everybody knows everybody, right? So my dear friend, who is the 4th precinct inspector, I call him all the time, Charlie Adams, who, he understands North Minneapolis and the pockets, as Keith Ellison was alluding to. The folks that are on the street, that are seeing it on a daily basis, understanding what we're dealing with and how we're dealing with it. It's kind of like this old school kind of mindset. Your mother knows the neighbor down the street, right? Your neighbor's going to tell on you if they see you doing something, right? And so that concept is now being put out on the streets, right? We have A Mother's Love out there. You have We Push for Peace. We have 21 Days of Peace. My good friend, Reverend McAfee, they're on 35th and Penn every day, feeding people, Narcaning people, and these are individuals that, they're kids. You see people that right? And so I think as a like that old school approach of just saying, hey, we see you, we're trying to help you, there's no judgment, right? Go to Turning Point, you know what I mean? So it's been interesting, and I truly appreciate the collaboration with the partnerships. I went to school with Mike Wynn over at Emerge, that's my high school buddy. I've got folks at North Point that we are re-engaging with, and just different community organizations that, there's no one subject matter expert. We all have our own expertise, and you have to utilize that. So that's kind of the approach that we're taking.
Thank you. My final question for you, Lori, is that we heard in one of the previous panels about the importance of listening to communities and doing this community engagement work, and you have to start with your research has to start with communities. So kind of thinking about what Anne shared too about this report that we wrote and the literature review and what's in the academic journals. What do you think research understands about your community? What do you think it misses?
Well, one is when we have these kind of research or outreach or sessions, you have to build that trust first and for people to talk about it. That's the hard thing. And honestly, you were a part of one of those sessions that we had at Turning Point, and there's a thing about trust in the African American community, right? And so telling the truth in those and to get the research, it's great, but sometimes you may not get the full thing until folks understand that it's okay to tell the truth. It's okay to say what's going on, because we're a very close knit and keep it to your chest kind of community, and that's how we were raised. I find it funny sometimes. My predecessor, Dr. Peter Hayden, he when I came on board, he's like, "You can't tell everything, Lori." Yeah, you can. You got to, right? You have to. Otherwise, how do we get help, right? And how do we treat that? But old school, right? And so we learned together how to not just be blatantly obvious with the information, but it's that trust, right? And building that with the older community, my generation, my kids' generation, we have to be able to trust and talk about it so that you get the data that you need.
That's right. Thank you.
You're welcome.
Yeah. So I lied. I'm going to ask you one more question, and that's just if you could share just a little bit more about that community conversation and what it was, what the intent was.
Yeah. So Jeff Hayden, a good friend of mine who actually happens to be Peter Hayden's son, brought this group together, and the intention was to just have people talk, right? And again, there were people that were boots on the ground, folks who were new to the substance use disorder arena, such as myself, and we just talked and just really just understood the impact of things like harm reduction and what does that mean, right? And so everyone has its theory or thoughts about harm reduction, and Turning Point, because Peter and I went back and forth on this. I'm like, they're not a harm reduction treatment center. Like, we have folks who are on drugs that are trying to get off of drugs, right? So we've never been that, but so that notion is this kind of a thing. But then you have individuals that have issues with harm reduction locations, giving safe needles, and so and especially in the African American community, why are we giving people a needle to continue that use? We want them to be off, right? We want to just be done with it. But but it makes sense in some arenas, and with some individuals, you have to just kind of meet them where they are. So we talked a bit about that. Had some very passionate conversation, and so, but passion to me is caring, right?
That's right.
And so we want to make sure that we're okay, I can't wait for the next session because there were so many different opinions and bringing some other voices to that conversation because it's important for us as a community to talk about it and feel comfortable in that. So
That's right.
yeah,
Thank you.
you're welcome.
Okay, so I'm going to turn to Chaz now. And Chaz, I want you to help zoom us out a little bit from what Lori was talking about, which is these very intimate conversations among neighbors. And how does that ultimately connect to the research report and the task force? And how does policy get made out of those intimate conversations?
Sure, thanks, Ari. I do want to say you can sit up here in this chair. I don't want you to stand. If you could just go ahead, that's fine. So it says reserved. I don't know who it is for, but that's all right. Reserved for Will. Good, very good. So that's a great question because how do you take practices on the ground research and then effectuate that into legislation? And just kind of like talking about kind of the history kind of on drug sentencing reform back in 2016. So that was sort of a state capitol miracle when that happened because at the time, the Sentencing Guidelines Commission was recommending changes to the sentencing grid. They could only make so many changes on their own without the legislature. And so as advocates, we decided to leverage that decision-making process. And I see Mark Hasse, he was in all of those meetings, very important player as part of that. To basically get additional changes we wanted, like eliminating some mandatory minimums, changing felonies to gross misdemeanors, creating a diversion of program for first-time offenders, actually making the changes to the sentencing grid that provided sort of safe havens for first-time offenders at the lower end of the offenses, so 5th degree, 4th degree possession. And we were able to leverage that to do that work. And I think that always the thinking was, we will revisit this, we'll see what it works, how it works, we'll see the research, we'll see the data. And a lot of states followed and made changes to their sentencing grid. And as kind of we've gone almost, 8 years with this new regime, the step back was, well, did it work? And I would say, yes, it did work because it gave a lot of people second chances that would not have received second chances under the previous grid. It reduced the impact to the Department of Corrections. We probably would be talking about building another prison under the old regime. We're not talking about that right now. And so, but then we go back to outcomes, right? We're looking at traditional outcomes that Ann talked about, like incarceration rates, arrests, things like that, and taking a step back and saying, maybe we should be looking at this from a public health response. Like, it's not just enough to say, let's change the sentencing grid, let's change mandatory minimums, that we need to look at illicit drug use from a public health response and looking at the holistic point of view. So that was what I think the genesis, what Representative Pinto brought forward. The report was like, we as legislators don't have all the answers. We tend to look at things, and so do people like me, as from a myopic viewpoint of changing some of the metrics, and maybe we need to step back and have the research presented to us, data, evidence-based, to tell us what direction we should be taking. And so that's what Ann and Ari are working on. They issued the first report late last year, or early this year. And then there will be a second report they're working on, and they're also working with the task force, which represents a diverse group of stakeholders who are looking at those recommendations, looking at the report, making some judgments, I will say, on some of it, and which is good. We want to hear from diverse stakeholders, from those with lived experiences in communities, to prosecutors, to defense attorneys, to law enforcement, and doctors. So we want that full spectrum of advice as we move forward. So I think what the good news is, if we look at, people always point to Oregon as a state, they decrimmed, and then they did that by vote. So voters in Oregon said, we want to decriminalize in 2020. And then there was a reaction of any little public safety problem was ascribed to the proposition that passed wrongly, rightly, Oregon's experience was they didn't have the infrastructure in place to really provide public health supports to people who did want to stop using. And so that was a problem. Money did not flow down quick enough to the counties, to the cities to respond, to have a full response that was necessary. And then there was a backlash, and they basically recrimmed, the legislature did, and they did that to try to stop a ballot initiative from going on the ballot. It would have been even harsher than what they did in recrimming in Oregon. So what we want to learn a lesson from that, right? We want to take a step back, look at the evidence, look at the data, have the task force weigh in, and really this is going to be a multi-year effort with the legislature and going back and looking at those 4 areas that Ann talked about and presenting the legislature with evidence-based, data-driven policies that we think that they should look at, enact, and look at a longer view on the public health response to drug use in Minnesota.
Thank you. I'm sure this question is in a lot of people's minds, especially if you're local to Minnesota, but it's going to be a divided legislature this year. How are you thinking about moving forward some of these policies that we've been dreaming of?
Sure. In my mind, I always view things from the long game. And that, Minnesota has this tradition of divided government. So even though the divided government looks a little differently than we thought, meaning we have a tied House, which hasn't happened since 1978 elections, we have always made friends where we can make friends. And our first goal is to try to get bipartisan support for the work that we're doing. Sometimes we're successful, sometimes we're not, but we've never stopped doing that. So thinking about the work that Mark Hasse and Will Cooley and others have done, we've intentionally talked to people who might not be this friendly. I can't say we convert everyone, but we do at least get them to understand our position and where we're coming from and the research and data behind it. And so that work is just going to continue. It might not happen as quick as we always want it to, but it's going to be intentional, and was always going to be a multi-year effort. It was never going to be, we're going to come in 2025 and change the world and get everything we want done at once, because we learned that from Oregon that it just doesn't work. You really have to build the infrastructure and build support, build the infrastructure, have the funding in place, have the policies in place, allow for time for implementation, and that's where we're going to have success at the end. So I don't think it changes the work we do. I think it might change some of the timing and what it looks like, but it doesn't change the work that we have to do.
Thank you. So the next thing I want to talk about is something that I heard from Mark Osler at lunch the other day. He and Chaz and I went out to lunch, and Mark Osler said, "Culture eats policy for lunch." And this has been ringing around in my head for a long time. And so I hear Ann talking about the importance of research. We know that syringe services programs work. We know that from 30 years of evidence. The legislature passed policy, so we have expanded syringe services programs in the state now with more funding. And we know that communities in North Minneapolis are really hesitant about those programs. So, Lori, what do we do with that? And I mean, it's not a question just for Lori, but Lori lives in North and serves North, so I want to hear from her. I mean, it's a question for all of us. Like, what do we do with that?
I think, honestly, to keep talking about it and having conversations. I think the hesitancy is just, it's the unknown, right? I kind of equate it, this is weird, but to COVID, right? And so when folks were going out and getting vaccinated, I was like, with my kids, I'm like, I don't know, it doesn't seem right, and then, my son said, "Hey, you're not going to see your granddaughter." I said, "Okay, well, I guess I'm doing it then," right? So, but I think it's just, education and conversation is the key, and it takes away the fear if folks are educated and understanding it, and it just takes away that just black cloud of the unknown, right? And so. That's what I think. Intentional conversations is what we need to do. Yeah.
Thank you. I appreciate that. Yeah, so the other statement that's been ringing around in my head recently is something that a colleague at DPA, Libero, shared. And he said to me, or to a group of us, perfect policy is not enough if you're not going to have communities that are willing to fight for it. Because at some point, that policy is going to go sideways, and there's going to be naysayers that say, see, I told you it's not going to work anyway. And unless you have communities that are ready to stand up for that policy, it doesn't mean shit, right? So, so my next question is, for Chaz, it's about how do you, once you have a perfect policy and it's written up and it has a bill number and everything, how do you communicate to legislators that the policy has community buy-in and support and that it's real?
Sure. I don't know that you could say any policy is perfect, right? I
Right.
mean, that's just, you have best practices, you have the research, you have the data, but the, implementation could go wrong, then it's not perfect policy. So I think the biggest thing is just making sure you build support for the work that you're doing, not just through research or data, but also engagement in communities. And that's why I think the work that Lori does, that you do, Ari, is so important. There's groups at the state capitol who are either citizen lobbyists or they are part of groups that connect with communities. And I think their voices are so important in developing the work that we do in passing of legislation and our presentation to legislators to make our, I guess, really it is an elevator pitch sometimes to legislators. And so that work is so important up front and needs to be continued. One of the things I will say, like, when you look at the election, like there was a proposition that passed in California overwhelmingly that increases criminal penalties. There's other things happening. And I think, when you look at some of the crises we have with fentanyl or other issues, people want solutions. So I think it's important that, this conference is focused on solutions. And I think that it's important that we continue that work and have solutions to what's happening, because if left in a vacuum, then it's let's just increase penalties, or that's just kind of responsive. I feel uncomfortable with what's happening. I know change has to happen. Someone's offering me a solution and no, there's no other alternative solution, so I'm going to go with the solution that sounds good. And so I think that it's important that we have the messaging, we have the community support, that we're not just stuck in the, no, there's no problems, we don't have to address this. I think we just really have to be upfront and just have solutions for legislators, policymakers, on the ground, and just know it's a continuum of work that has to happen.
Thanks. Yeah, something that makes me think of is like when we were talking about this research report at the very beginning, Representative Pinto shared that originally he had conceived of this as a task force. Like he would create a task force, and the task force would bring all their policy ideas to the table, and the best policies would come from that group. And then ultimately he said, I don't know if that's going to bring the best policies forward. Like, is that where we're going to get the most cutting edge, the most forward-looking, the most progressive policies? And so ultimately he hired a couple researchers to say, actually, this is what the evidence is saying, knowing that sometimes group dynamics can end up watering the recommendations down. So this question is for Anne. Like, can you maybe something from the report, but maybe something in another area of work where the research has surfaced something that's really counterintuitive, that really moves the evidence forward, but maybe, like a group wouldn't have thought of that idea, wouldn't have thought of that solution. I'm kind of putting you on the spot because I didn't prepare you for this question. And I can think of one I could think of one if you don't have one, or if Lori or Chaz have one too.
I would be curious to hear the one that you're thinking of.
Okay, I mean, the one for me, honestly, is overdose prevention centers. Yeah, and Lori will comment on this too, because this is another area where there's tons of research supporting this as an intervention, and the communities where these things are being placed have a lot of questions and aren't sure if it's the right thing for them. So we have decades of evidence showing that these things are very effective in stopping overdose. They bring people inside, they connect folks to services, all kinds of good things follow from them. But if you were just to ask somebody on the street, like, we're gonna give you a space where you bring your own drugs and you come inside and you use your drugs, And this is going to improve all your health outcomes, and it's going to be good for the community too, because there's not going to be syringe litter on the street. Like, what do you think about that? And I think for those of us not in this bubble, maybe not in this room, it's incredibly counterintuitive. Like, you care about your neighbor or your daughter, whomever, you want them to stop using drugs. And what the experts are saying is, actually, please continue to use your drugs. We're just gonna make it a little bit safer. You might say, excuse me, what? And I think that's because all of us have come up with this drug war mentality, punitive approach, punish somebody if they're doing something that you don't like, freeze them out, whatever. But that's just not what the evidence says. Yeah. Oh, I'm getting a 10-minute mark. So I'm gonna wind it up here and just say, yeah, of any of the three of you, do you want to respond to that about this question of evidence versus communities and how we leverage research to move it all forward? No?
Well, I'll just say one thing again. Evidence is one thing, but then what makes this community feel good is that's not right. You know what I mean? Like it just kind of goes back and forth, and it goes back to the trust. And really, can we trust that? Where'd you get the information from? You know, that kind of this thing. And so, but intentional conversations that talk about it, and because the numbers are the numbers, right? And so giving this community, my community, that information, I think, is key, right? And so, but that's a tough one.
Yeah.
It really is, yeah.
And it'll probably feel better coming from you rather than from me.
Yeah.
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 Okay, so the last thing I want to say is that all of you, I hope, will get involved with this work. So I mentioned at the beginning that we're building a coalition. It's called impactmn.org. And Lauren, would you mind writing that on the pad of paper there? So we're working on this statewide with a coalition called impactmn.org. We've got an amazing executive committee consisting of folks from MNJRC. Will is on our executive committee. Turning Point, Lori is there. Drug Policy Alliance, as well as Harm Reduction Sisters, a syringe services provider out of Duluth, and the Minnesota Coalition for the Homeless. So like I said, this is the outside game to the research and task force's inside game. We're going to hold their feet to the fire and build this kind of community support that Lori is talking about that's so incredibly critical to doing this work statewide. We have our first all-coalition meeting on December 11th. If you go to Impact MN, you can RSVP for it there. The more the better. We want to attack this from all angles. We want to reform SNAP and TANF. We want to make sure that if you're pregnant, you can talk to your doctor about it and not be separated from your baby. We want to keep folks out of prison. So anyway, would love to have you all involved there. Okay, do I have any questions for the panel?
Yeah.
Quick thing, Ari. So can you give the website address one more time? And I think you can sign up for updates, correct?
You sure can, yeah. It's impactmn.org. Thanks, Lori.
I've got the mic, and it is being recorded, so I will bring around the mic, introduce yourself, and ask a question. Mark, do you have here?
Thanks. Mark Hazy. This is kind of a technical harm reduction question, and I thought of it because of what you said, Ari, early about feeling versus facts, I think. And just quickly, if anybody wants a really great book on the war on drugs and somewhat harm reduction that I read recently, Johan Hari's Chasing the Scream. You guys give that a thumbs up?
Oh, yeah. So classic line from that, the opposite of addiction is not sobriety, it's connection.
Yeah. And I thought I knew something about the war on drugs before I read that, but really good. Anyway, the use of syringe exchanges, to me there's a feeling thing about syringes. It just seems so, so bad, right? But the start of that book, they talk about how doctors prescribed some of these drugs, and people were very successful. And have there been efforts to use things besides syringes, in these types of sites that change that feeling about syringes? If that makes sense.
Sure, I can take stab at that. I'm not sure I'm getting your question right, but I think so correct me if I'm going the wrong direction, but part of harm reduction is talking to people who use drugs about safer ways to use. And so you can kind of give a hierarchy of safety, where injection is one of the least safe methods. And safer methods include smoking, taking pills, that sort of thing. So that is one of the counseling techniques that's part of harm reduction.
I'm thinking more of the public, like how we talk about them, because often at your injection site, when maybe something's happening there that's not about allowing people to continue to inject drugs.
I see what you're saying. Yes. So there's a lot more that actually happens behind those doors of OPCs as well as syringe exchange programs, and a lot of that is connection to care, linkage to services. And this is an answer to the surprising evidence. If you were to compare syringe exchange programs with more traditional abstinence-based outpatient services and who gets people in the door to treatment, syringe exchange programs do 8 times as many. And part of that is about trust, what Lori was saying. If you can have people in the door and feel like they can be their whole selves and talk about what's actually going on, then they're more likely to come to you when they're ready to access treatment. And so a lot of what's happening in those places that makes them so successful is that trust building that then can lead to linkage to care and other services.
Tom Sorensen with Regional Native Public Defense. I just wanted to say I appreciate the thought of holistic, looking at all aspects of it, because that's kind of the route we take as our organization, is looking at the chemical health. We represent tribal members in criminal court. So we have attorneys, but at the same time we have LADCs. We create relationships with the community to build that trust, because they'll say, oh, I don't want a public defender. Well, we're public defenders, but at the same time, we built that trust with the community, with grandma, with auntie, and so when auntie has a question, she comes into our office, and we have answers for them, and so even probation officers creating unique solutions to their issue, the problem that they're dealing with, and understanding that on tribal communities, they're so small. And everyone knows everyone. And so we want to know them too. So that when they come into our office, they're like, oh, they all know our names. We walk down the street, they know our names. So I just want to say I appreciate that when it even comes to drug use. I think when we look at solutions on all levels, we have to look at all the problems, but the solutions. I mean, we all know the problems, but let's talk more about the solutions. So I appreciate you guys' panel.
I love that.
Hi, Sarah Silva. I just wanted to present a different perspective on the way we think about drugs. In the beginning, and this is just forward thinking, it was said that drugs are being thought of at the border, right? But it was produced by the pharmaceutical companies here, so I want to make sure that that's corrected. And it's the pharmaceuticals companies that are creating this problem with no accountability. They rather do a cop-out, if you will. Also, I want to state that drugs do get passed through Mexico. The opioids were not being grown there. So that's also 2 very different things, whether they come through and they weren't being grown there, nor did Mexico have an opioid problem until now. And because of that migration into the U.S., I hope that the bill that you are working on, again, there's no right or wrong answer to any of this. I don't know what it entails even. But I hope that there is protection for non-citizens who have now been exposed to opioids,
Yes.
That there isn't a repercussion to getting deported or losing their immigration status. So that's all I wanted to clarify. Thank you.
Thank you so much for offering that. And I wanted to say that in the report, which if you go to this website, you can find a link to the report that we're referencing. There is a small but mighty section on immigration and its intersections with drug policy. And it lifts up exactly what you're talking about, all the ways that folks get caught up in the system. And Melissa, can you stand up or just offer, what's the name of Drug Policy Alliance's report that's on yes, and the new one about immigration.
Oh, yeah. It's Human Rights Watch?
Yes.
Yeah, so DPA did a report along with Human Rights Watch on the compounded degrees of additional punishment that land on immigrants for drug crimes in specific. So if you go to drugpolicy.org, you can find that report on there really easily.
Awesome. Thank you for lifting that up, Sarah.
Hi, my name is Dante. I just have confusion. I'd heard or I read that the panel was on the vision for kind of what drug policy can look like. I haven't really heard much on that. I really came to hear about, I think the policy was passed in 2023, that safe use sites, I think you called them harm overdose reduction. Safe use sites are legal for the state of Minnesota. I haven't heard about, so I was just on the Minnesota website. I'm not sure if I'm reading it wrong, but it says that they are. I would have loved to hear more about it during your questioning phase. I guess my question is, because I'm really confused. I've been doing work in community my whole career, and I'm hearing that part of the pushback to the safe use sites are community, which would be surprising to me, like I said, from the community that I'm a part of, North Minneapolis, born and raised. Because we already have safe use sites. They're called bus stops. And people stand next to fentanyl users, weed smokers, alcohol drinkers, in safe spaces every single day. So as a community, we have already, kind of handled that. And so I would opine that it may not be the black community that has the issue and is doing the pushback, but maybe the policymakers that are from the white community. And the two panelists, you seem firmly entrenched into the white community. Could you offer any solutions that the white community could hear that they may be more comfortable if the pushback is from the community? I just don't think it's the African American community. How can we address the white community and get them to see safe use sites as a place that are going to be good in the community a whole?
Well, I mean, what I wanted to say was that I think this is even though Lori is black, I mean, what I heard Lori saying and what I experienced in this community meeting was that it was black community leaders that were expressing some uncertainty, right? It wasn't white folks, although I super hear you, white folks are often doing the pushback. But Lori, do you want to, can you share more about what community was feeling about those sites?
Yeah. So, North Side born and raised as well, right? That corner on 35th and Penn that I referenced, Reverend McAfee often talks about the folks that they are saving on a daily basis. And so the notion is that if we put a safe house in the neighborhood, then what does that do? Are we saying, okay, it's okay, Lori, for you to go in and do what you got to do, but then they come out, and to those community leaders, they're like, we're saving them coming out, right? And so it's kind of it's a real hard balance, and I wouldn't say it's totally us though, but I grew up in that neighborhood. I grew up, 12th and Upton, and going down to Penn. That was my stomping grounds, and I never really could even imagine how people on the bus stop. My dad used to spray the bus stop down because people were just down there hanging out, right? But we didn't have that, and so now it's different, especially with my age group and a little bit older that think, well, wait, what are we doing? So it's kind of a thing. I wouldn't say it's all of us, but I think there's a lot of community leaders that are concerned about it. So.
Hi. I have a question about how this, like, if any of this relates to youth, or even how much research has been done on young people and harm reduction. I know it gets a little more complicated because there's a lot of like parental rights and parental's permissions involved, and you really tell a parent that you're going to give their kids like syringes or drug paraphernalia, they're not going to like that. But still, like, what information is there for about youth?
And do you want to respond to some of what we heard in our interviews?
Sure. Can I go back to the race conversation for a second, though? Because I have one thought that's still on the top of my head, because I really appreciate what you said. And I think that and then I promise I'll get to youth. And youth of various races. I think that that one powerful way of getting to white people in power is by naming not rates, but raw numbers. Because the raw numbers of people who are dying of overdose are, in this state, still by and far mostly white people. And so this is a problem in our community too, and it is not a problem that is just associated with race. It is not a class problem. It's a problem that, like you said, came from the medical industrial complex and affects all of us. And so that's, and so the two arguments that I use when I'm going to people of power to argue for these types of services is, one, it's just the more humane, right thing to do. Yes, people could use at a bus stop. If I were addicted to a substance, that's not where my first choice to use. I would prefer going somewhere where it's not cold and raining and where I'm treated with respect and I can sit down somewhere and not be asked to move by the cops every few minutes and can put my stuff somewhere safely and not have it stolen. And then if the humanity argument doesn't work, it's also more cost effective, which I hate using that argument, but we can pull that one out there too, because it is. So that was just the piece that I wanted to answer there. Youth. So, and Ari, feel free to chime in, but yes, we talked to several people in our key informant interviews who serve youth populations, and it is an area that is understudied, yes, but even more so underserved. And so one of the areas of recommendations in our report is specifically the need for more resources for youth-specific services, because their needs are different in a lot of ways than adults. And the other piece, one example of that is that youth who are using drugs who are caught up in the system are often homeless, coming out of foster care, that sort of thing. And they are more statistically likely to be a part of the LGBTQ community, for example. And youth services in the addiction world are primarily offered, not primarily, but often offered by faith-based groups, which sometimes is a place where people who identify as LGBTQ may not feel safe. So that's just kind of one of the ways in which youth services needs to think a little bit differently about how care is delivered than adults. Ari, did you want to add anything more about
I think that's great.
youth?
Thank you.
Other questions? I don't know what time we have here. What time is it? Oh, 3 minutes left? Yeah. 3 minutes. Any last questions? All right. Well, let's thank our panel. Thank you very much.